just to kind of give us a sort of a status update where the industry is around MIPS. And then I always like to kind of help, point out how you can use your resources within your practice to sort of implement some changes, especially going forward this year, because now's the time, if you skipped out last year or you did the bare minimum last year, you definitely want to make sure that you're doing more than that this year. So we'll touch on a few of those kind of helpful hints too. So we'll go ahead and get started here. Just to remind everyone, I know we're kind of in the last leg, I guess you could say, of the marathon that was last year, trying to wrap your heads around MIPS and what it was and what path you wanted to take. But just to kind of reiterate some really important deadlines, the last day for groups to report data through the CMS web interface was March 16th. So that has already come and gone. That leaves the QPP portal, which is how most clients are attesting for MIPS this year. And that allows you to attest individually all the way up through March 31st. Okay, so you can see that deadline there on the timeline. CMS has said that they're going to provide the performance feedback in that window from April 1st all the way through to the end of the year. I wish I could be a little more specific about when you can see your data and how well you did. I do know that they've said you can see your quality data, performance data on the website or on the portal about 2 weeks after submission. So for those of you who did go ahead and submit early in the quarter of this year, you might be able to see that. You won't be able to see the other categories, though, on the CMS website as far as I've heard. So you just kind of have to stay tuned, and if we get any information about any updates or CMS provides any more information around that, we'll certainly let you know. And then, of course, January 19th is when those either penalties or positive payment adjustments are going to kick in for that 2017 data that you submitted. All right, so I get a lot of questions from practices about, I've heard MIPS is going away. I've heard, it's not going to be around next year and they're going to do away with it. Are we doing all of this for nothing? The best piece of information that I've come across from MedPAC, and it's been floating around since around January of this year when they met, they considered, whether to recommend that they eliminate or replace MIPS. And, all the commission's members, they did agree. However, they didn't agree that it should be eliminated and nothing put in its place. They suggested that it be replaced with another acronym called the VVP, or the Voluntary Value Program. It sounds very similar to MIPS, though, if you really start breaking it down. Not a lot of details around it, but a summary of what they had proposed. Basically, it's still going to be sort of quality, pay for performance. And you're still going to be compared with your peers on these quality of care measures, but they're going to make it a little bit easier, and basically just the physician's performance on the measures is based on their claims instead of having providers report on the measures. And then physicians with the higher scores obviously would receive the incentive payments. So that takes a lot of that, the work off of the provider when it comes to the quality reporting separately from the claims. I do know a lot of physicians already use claims today, and that's great. But now realize that that's something that they're going to have to flesh out more, because as it stands, you can't use claims alone. So I would not in any form or fashion recommend that those who used claims last year just sort of lean on that in the hopes that this goes away, because we all know how fluid these programs are, and any changes that CMS would make would take a lot of time to implement. So don't get that stuck in your head that, I can just lean on claims continually for this next year, because we're going to talk about some reasons where you might not want to do that. And then, so the ones that decide not to participate in any of these, value-based payment models, they're still going to have a certain percentage of their Medicare payments withheld. Now, what that withholding is going to be, what that percentage is, nobody knows. I don't even know that it's been proposed. So, like I said, there's a lot of information that floats around, and I think that this one probably does carry some weight. It'll just kind of be one of those things that'll be interesting to see how it unfolds and what changes actually are seen all the way through to fruition in the end. So we'll stay tuned on that, and obviously, if we hear anything or Advancem gets any updates, we'll certainly push that out as well through Stacy. So I said that if you didn't participate last year, you're going to be hit with a penalty. But if you participated minimally, you really want to reconsider, what your options and what your thought processes are going forward, because they've kind of doubled down on what they want you to do, especially even passing with a minimum score. So we'll walk through a little of these, but I just want to reiterate, why do MIPS, or macro, what does it matter to me? And I like this quote from the ONC that says, having the right information at the right time supports team-based care, strong care coordination, and effective patient and family engagement, which many provider communities have recognized are fundamental to an efficient and effective care delivery system. So basically, their stance is, value-based care, pay for performance, and improving outcomes and the quality of care is really, the crux of what they want to do. It's the advanced alternative payment models. It's the patient-centered medical homes. They're not backing away from that. And participating in MIPS is a really good way to get your feet wet. It's a good way to segue into that, those bigger programs like the AAPMs. And it gives you a little bit of breathing room, and it's not quite so overwhelming. But you can see by this statement alone, that's where the industry is still headed. So MIPS is still going to be a very vital part of getting from point A to point B. So, talking about, what the ONC has said, they want to improve healthcare quality, safety, and efficiency. They want to reduce health disparities, engage patients and their family members, and improve care coordination and public health. All of these things are requirements in advanced alternative payment models, and a lot of these things can already be done on the MIPS side through your EHRs. So, why not get credit for the things that you've already started incorporating in your practice? Because like I said, it helps you get your feet wet, and it helps put you on that path to that value-based care. Just to give you a couple of examples, because I know outcomes are important, people want to say, well, show me, the proof is in the pudding, right? A Colorado-based value-based payment model, they reported a 15% decrease in emergency department visits, an 18% reduction in inpatient admissions, and a return on investment of $4.50 for every dollar spent. Okay, that's really important for the healthcare industry, which goes back to that ONC statement. Another example that I came across is that a PCMH in Maryland stated that it saved $98 million and increased their quality scores by 10% in 1 year. So, MIPS really gets you focused. It really helps you utilize the EHR that you have. Perhaps you've got an EHR that you're using, but you're using it minimally. You're not maximizing, the efficiency. You haven't optimized it, because if you do those things, it's really going to set you up to save the money that you see here. I mean, this is black and white on paper. This is data. So, go ahead and start using that EHR to align yourself with the MIPS goals, is what I'm trying to say. And here's one of the bottom lines. There's two bottom lines. Eventually CMS, they aim to tie all Medicare payments to value-based care models. So, and that goes back to that, in the news slide, a few slides back, it doesn't necessarily matter if it's called MIPS in 3 years. The bottom line is that it's still going to be leaning toward value-based care. No one sincerely believes that that's going to go away, just because of the data that's coming out in the two bullet points you see here. It obviously is making changes. So I cannot see that it's going to go away. And I like this slide. This is actually geared toward, this is from CMS, and this kind of demonstrates what's happening to practices based on, predictions and then the data that they're seeing coming in from MIPS for 2017. It's really interesting to note that the small practices are the ones who are really likely to be penalized. They're the ones who probably don't have the resources. They haven't optimized their EHR, and they really haven't, taken the time to educate their staff, their providers, and may not even have those resources to do it. But the small practices are the ones that are going to be most likely affected by MIPS, especially going forward as those penalties increase year over year. So it's just really something to note. If you're a really small practice and if you haven't thought about it, or you just haven't bitten the bullet, so to speak, now's definitely the time to do it. This is the other bottom line. So I mentioned, that CMS, they want value-based care, and they're really putting their money where their mouth is, because they're putting 4% of your Medicare collections on the line. So if you think about that, I mean, for even a smallish practice, it wouldn't be unheard of. That's an extra $200,000 that could swing either way. Who couldn't use that extra revenue in their practice to either grow it or help optimize some of the resources that they have in there today and make life easier. And on the flip side, who can afford to lose that much? If you are a smallish practice and you do a lot of Medicare, 4% can really add up, and that's just for this year. So, and we'll talk a little bit about some of those changes as those percentiles are going up, because now I want to touch on what happened in 2017. The final rule has definitely tweaked a lot of the requirements. It's added some requirements, and then in the same sense, it's tried to ease the burden a little bit regarding some of the measure requirements. So it's sort of a swing both ways, and it can affect whether or not you get any bonus or you get any percentage of penalty. So I want to highlight what has come out of the final rule as being key, and things to note if you thought you could just do things the way you did it last year. That's not the case. So I do want to talk about probably what I would consider to be the top changes in the program for 2018. And now remember, any changes for this year will be reflected in 2020. All right, the first one, we've just talked about that 4% on the line. Well, next year it goes up, so it's plus or minus 5%. Okay, even though it's only 1%, that can still be a significant amount of money. And if you see to the graph on the right side, with every subsequent year, it's going to go up, up, and up. Now you're talking in 2022, you're looking at almost 10% of your Medicare claims. Now that's plus or minus. That's a huge swing, even for a tiny practice. I can't imagine at that juncture that anyone that collects any Medicare whatsoever would risk taking a hit on that, because you're literally giving money away or you're leaving it on the table. So, like I said, last year was a really good time to get your feet wet because it was a transition year. So is this year, but the stakes are definitely going up. So we're going to talk about a few of those things too. The next one, this is sort of this is helpful. Okay, like I said, they're trying to ease the burden in some areas. So in 2018 or 2017, I'm sorry, it was $30,000 or more, right? And more than 100 beneficiaries for MIPS to be included. In 2018, they have raised that to $90,000 in Part B, or 200 beneficiaries. That will affect some providers. Others, it just depends on the size of your practice. It's one of those things that I would suggest you go ahead and get on to the MIPS participation lookup tool to see if your NPI is included in MIPS, and that will help you. That will kind of help you plan this year as well. Another thing that's changed this year, the performance threshold. Like this for 2017, it only took you 3 points to avoid a penalty. This year, or for 2018, I'll say, it's going to take you 15 points. All right, so no longer just submission of one quality measure. You're going to have to submit at least 2 to 3 quality measures for improvement activities, or all of the ACI-based measures instead of pieces of those. This is more challenging for the providers, I think, and this is where I feel like they're doubling down a little bit and saying, you know what, we're going to still give you some things back, but we're also going to make you work a little harder. And for those that are in really niche specialties, 2 to 3 quality measures can be challenging to find something that are applicable to your specialty. So just be aware that it's no longer just the 3 points. The cost category, they had discussed in the proposed rule, pushing that off another year. Well, the final rule came out and they actually decided to go ahead and include that category, which has caused some reweighting of the categories, which I'll show you in just a minute. But the cost category is going to take effect this year, started January 1st. It's going to add, it takes 10% basically out of the quality category and puts the weight onto the cost category. It's based on the Medicare spending per beneficiary and the total per capita cost for all attributed beneficiaries measure. This could have an enormous impact, especially for clinicians who prescribe a lot of really expensive drugs. Like I said, those niche specialties, rheumatology, a lot of those biologics, things like that. So make sure that you realize that cost will now be a factor. There's nothing that you have to do on the cost category consciously, such as submitting measures or collecting numerator and denominators. These will obviously all come from your claims, but I just want to make it known that the cost category did come into effect this year instead of next year. As a result of that, number 5, the categories are reweighted. And I mentioned that quality's weight is now gone down from 60 to 50%. The ACI and the IA categories will remain the same, 25 and 15%. This is just a visual just to show you where the weight lies within the categories. Remember, if you just want to do the minimum performance, that left category, you can do 2 to 3 measures in the quality. If you want to participate and have any chance for any percentage of positive payment adjustment, you now need to participate in all 4 of these categories and do well at that. Virtual groups, this is new. They've been talking about this all year. It's a very interesting concept. To me, it's sort of like creating an ACO without creating an ACO, if that makes any sense. It basically allows a group of providers to report as a group, but they don't actually belong to a group. They don't belong to an ACO, or they haven't group attested in the past. And it can be several different practices. So either a solo provider or 10 or fewer providers, they could come together virtually with at least one other practitioner or group to participate in MIPS for a year. So basically the smaller practices can kind of all get together as a collective, and then they can submit as a group, which can ease the burden, right? Because it's all performance categories, all the requirements are submitted as one group, as one collective entity. So that can either help or hurt, just in the way that a group was. So what CMS has basically done is tried to ease the burden of those small practices who say, hey, I've got 6 providers, but it's really hard. I don't have the resources for someone to monitor all of their analytics and their data and make sure they're doing well. I'd really like to, attest as a group. So they can come together and do that. It'll be an interesting concept. I'm not really sure how utilized it'll be or how it will actually work. I don't have any clients that have even expressed interest in becoming part of a virtual group, but it will be interesting to see how that plays out this year. I'm sure we'll start getting a lot of feedback about it. Another key change for 2018, which is really helpful this year, especially, is an extreme and uncontrollable circumstance exemption added. Once again, CMS is trying to throw us a bone here, especially for really heavily impacted areas, for physicians who can't meet the reporting requirements due to hurricanes, natural disasters, or other public health emergencies. This is of note. It's not only going to apply to this past year, but it's also going to apply to 2018. Okay, so the application deadline for any of these exceptions will be December 31st of each year. If they don't submit any data, now they will be exempt from penalties. However, you had to have applied for 2017 by December 31st. If you were impacted in 2017, well, I just mentioned that. So you have to submit an application for reweighting of the ACI category, but for 2017, it's already passed. This is really interesting, though, because I am in Florida, and so I did do this for a couple of clients because we did have a hurricane this year. So things happen, life happens, and sometimes you just can't. It's uncontrollable, and at least CMS is flexing a little bit on some of these hardships. Another change that I thought was definitely helpful for small practices, especially since they're the ones that seem to be the hardest hit with all of these requirements. CMS is automatically going to award qualifying practices a bonus of up to 5 points. They must have 15 or fewer eligible providers and submit data on at least one performance category to be eligible. So what that means is if you can demonstrate that you are, you're a small practice, or you check that box per se when you're attesting, then you maybe instead of 3 quality measures for that 15, you only need to do, 2, depending on how much they're weighted and how well you do. The last 2 things that I kind of want to highlight are kind of give-me's, and I think that they're good to point out because it's nice to know that they're not really forcing your hand on your EHR and the HIE, and we'll talk about that when I get to number 10. But for 2018, they are going to continue to allow providers to use EHRs that are 2014 certified. Okay, this came as a result of the fact that a lot of vendors were just not prepared for the changes with MIPS. Sometimes CMS can put the cart before the horse in the sense that they roll out these requirements and these expectations, but vendors, need time to develop the software. They need time to get the software certified. So, a lot of times the window is just too small. So they're offering a 10% bonus though, if you do report with a 2015 certified EHR. Now the catch is you can't really dictate that. Okay, but just be aware that when you do attestations, there will be a box that says, are you using 2014 or are you using 2015? Make sure you know the answer to that question. A lot of softwares are still on 2014, but then a lot of them have upgraded. So just make sure if you can get those points, you definitely want to take advantage of that. The last thing is something that all of the clients I've ever worked with constantly struggle with, especially small practices and especially rural practices. Sometimes it's really hard to meet certain measures when it involves e-prescribing, but mostly health information exchange. Not everyone uses direct messaging. Not everyone has the capability to send out those referrals and get them back. And sometimes it's through no fault of your own. Perhaps there are no providers in your area that are capable or have the capability or the software to accept those referrals. So at least they are giving you an exclusion finally for not being able to do that. I think there's a lot of fear that that was going to go away, and it was supposed to. So it's nice to know that at least they've not only kept it, they've even kind of retrofitted it to 2017 and 2018. So that's really handy because I do know there were some clients that were struggling with that particular measure, but just simply through no fault of their own. To claim this exclusion, you have to write fewer than 100 permissible prescriptions during the reporting period. And for that's the ERX exclusion. For the HIE exclusion, you have to refer or transition fewer than 100 times during the reporting period. And I know that a lot, especially multi-specialty groups, they don't do a lot of referrals. So that affected them negatively, and it was through no fault of their own. So there are a lot of people out there I think are going to benefit from having this. These 2 exclusions added. Real quickly, I know you guys are probably been doing MIPS all year. Like I said, this whole briefing was really just to kind of update you on the changes that have come out of the final rule, which are really important to note going forward this year as you plan and think about what you're going to do for your practice. But I'd just like to reiterate really quickly, super high level, how you can participate in each category. The quality category is now going to be 50%, right, instead of 60%. So we got 50% of the total mixed score. It's worth 60 points. This was, as we know, this was your old PQRS, right? So these are the quality measures that you find and you submit, whether it be through claims, whether it be through the registry, or whether it be through EHR. The requirements for getting the total score, the whole 50%, is that you would report on at least 6 of these quality measures. And one of them must be an outcome measure unless there's not one available. And that happens a lot to specialties. So if that's the case, make sure you report another high priority measure in its place. If you go onto the QPP website, it will tell you whether or not a measure that you want to select is a high priority measure or not. That will help you kind of decide which ones you need to pick. Submit 365 days worth of 2018 data, okay? So that's key there. You're gonna wanna submit as much data as possible. And if just as a side note, if you're reporting through the web interface and not using the QPP portal next year, you need to report 15 quality measures. Okay, so I think those, I just wanted to highlight those 4 kind of things to note out of the changes within each category. The ACI, we know this was your old meaningful use program. This is a very confusing category. I'm not going to go too deeply into it here, but basically with all the bonus points and the registry and the performance scores, you can get 155 possible points, but you're going to be capped at 100. Okay, and you need to reach 100 to get 25% of the total MIPS score. And this can be a performance period of 90 days. And just to let you know, the whole thing can be reported for 1 quarter again next year. You're not required to report for the whole year. Obviously, if you're looking for an attestation, you would want to do that. But if you're still looking to just kind of get by with doing the extra steps that are asked of you this year, 90 days is still fine. The requirements for the ACI category is that you have to report all 4 base measures. If you don't report all 4 base measures, you will not pass this category. And then there are additionally 7 performance measures to help you get to that 100-point threshold, because all 4 base measures are only 50% of the 25% of the MIPS score. So you see why I say it gets a little confusing, but they give you enough things to pick from, enough performance measures and enough bonus opportunities, especially around syndromic surveillance and immunization reporting, registry reporting, things like that, that you shouldn't really have too much trouble getting to 100 if you're going for a positive payment adjustment. And then finally, well, not finally now, we got to talk about cost too, but the improvement activities is still worth 15%. Nothing's changed around that, and it's the 90-day reporting period. So you've got to report. There's 2 things. There's a combination. There's different types. Some of them are highly weighted, and some of them are low weighted. But you need to pick up to 4 measures to equal 40 points. So some of them are going to be worth 10, some of them are going to be worth 20. So you've got to kind of decide which ones are something that you think is reasonable to put into your practice, and make sure that you've got documentation, you've got workflows, you've got SOPs. You need procedures in place that if you are audited, you can prove to CMS that, hey, we did implement these workflows and these changes in our practice. Groups that have less than 15 participants in a rural or kind of a rural health professional shortage area, they may attest to 2. All right, so they're going to cut you a little more slack there. And just to note, for anybody out there who is a patient-centered medical home, and more than 50% of the practices are recognized as a PCMH, you don't have to do this category. Okay, in fact, the only thing that you're really required to do as a PCMH is the advancing care information. Finally, new this year, we mentioned this a couple of times, 10% of the total score. I do think that might go up a little bit next year. We'll have to kind of stay tuned. This is formerly your value-based modifier. They gave us a break from it last year, but they thought about giving us a break for it this year, but no such luck. So the good news is this is the easiest category to deal with. We said it's your MSPB and the total per capita cost measures in 2018, and they're going to calculate the cost score. So you're going to receive a score for your performance on those 2 measures. And no, the good news is there's nothing you have to do. They will just send you information and tell you how well you did. Now that score is worth 10% of your total MIPS score. So at least it's not really heavily weighted if you're, not pleased, or there was issues with your claims or your billing. So, you've got plenty of room to make up for it if you don't feel that was turned out okay. But just be aware that they are slowly starting to pull that in. So here's where it all falls out for 2018, which is we'll see all these results in 2020. If you don't get 15 points, whereas last year was 3, you are going to get not a 4%, but a 5% reduction on your 2020 Medicare fee schedule. 15 to 100 points, CMS will take the funds of those who did not meet the threshold, right? So they're going to take, the money that you're going to be penalized, and they're going to redistribute it among those who did meet the threshold. So anyone who scores between 15 and 100 will receive some portion of those funds, right? Up to a 5% increase. So it's sort of a redistribution of the wealth, so to speak. And the ones who decided not to participate are the ones who are going to provide those monies. Now, if you score 70, you're pretty much ensuring yourself that you're going to get a positive payment adjustment. It's called the exceptional performance bonus money. So they've set aside, in addition to the redistribution of the penalties, they've set aside an additional $500 million to distribute to anyone who scores at least 70. So this is on top of whatever portion of money you receive from those who did not participate. So you can see there's a lot of money at stake going forward with these the positive payment adjustment plus the exceptional performance bonus money. I think some people don't tend to think, they think, well, hey, what's 5% of my Medicare claims? I don't really do that much. But if you do well and you've got the resources and the procedures and processes in place, you do well, you're really setting yourself up for a lot more money than just that percentage of positive payment adjustment. Same ways to report next year with the addition of the virtual group, but individually is how the majority of providers tend to report. That's just your NPI tied to your 10, right? A group is going to be the group of doctors who come together. They all have individual NPIs, but if you share a common 10, and that is your business 10, then you're going to report group level data for each MIPS category, or you don't have to. But if you all share the same 10, you will tend to do that, okay? If you have a bunch of physicians, like I'll give you an example, that maybe 2 of them don't do the same thing as the other one, that's a great example of why you would not want to report as a group. A large practice, which is greater than 25 providers, they can choose to report, remember, the CMS web interface. Remember that closes a little earlier than the QPP portal, so just bear that in mind. But if you do this, you must report 30 plus measures with a full year's worth of data. If you plan to submit using the CMS interface, you must tell CMS by June 30th. Okay, so you have to register by this June, and it will close down a little bit sooner next year than the March 31st deadline for everyone else. And then the new way, like I said, this is new for everyone. So this it'll be interesting to see how this one actually works. I don't have any information. I haven't had anyone even ask me about this yet. So I'll have feedback on that as the year goes along. But individual clinicians and small groups, they can form that virtual group we talked about, and they can report together as a group. It's got to be 10 or fewer, though, and as a group, and you have to exceed that low volume threshold together, which, if you put 10 together, then you probably will. And this is just a note. I noticed on the CMS website, if you do choose this route, you've got to tell CMS prior to December 31st of 2017. So basically, if you were going to do the virtual group for 2020, you would have had to already decide this. And based on the fact that no one has really notified me, or I haven't dealt with any clients that have really wanted to go this path, I'm not sure how popular or how this one's going to pan out. So we'll just stay tuned on that one. So what can you do? I like to tell practices there's a lot of little things that you can do, especially if you kind of stuck your head in the sand last year and you thought, okay, now what do I have to do this year? There's some things you can do that just really aren't that difficult, and it's probably things that you're doing anyway. One of those key things being, get the patients involved in their care. Almost all the requirements, all the measures, all the EHR requirements are all things that you're doing anyway. You're e-prescribing. You're giving them copies of their medical records. You make sure they keep and make their appointment, or make and keep their appointments, and you're not getting a lot of no-shows. All these things, if you think about it, when they're in black and white data, it really can help demonstrate, the quality of care that you're giving patients. So if you're already doing these things, provide education on their chronic conditions. That's a requirement. A lot of the improvement activities are built around, did you give the patient, their chart or a copy of their medical record, things like that. You're going to be doing that anyway, so you might as well take advantage of it and at least avoid a penalty, or maybe even set yourself up for some additional money. Documentation is key. That's one of the first things I like to do with clients, is go in and figure out, how is their workflow today? What kind of measures are reasonable in this practice? We don't want to reinvent the wheel. We'd really rather work off of what a provider's doing today and make it as seamless and as least amount of stress we can possibly induce, because that's kind of counterintuitive to this doctor-patient quality of care relationship that the ONC is really looking to have. Yeah, workflow analysis, look at your workflows, see if you're doing things, completely in a non-efficient way, see if there's room for optimization. Those are always things that we can help you with as well. Like I said, make sure the measures you pick are measures that actually happen. I've seen so many clients pick measures and all the numerators and denominators are zeros because they would never do things, like that in their practice. I mean, for instance, a dermatologist, does not need to have a colonoscopy measure on their dashboard because it's going to read zeros. So why pick that measure when it's not realistic to do? And I know that sounds kind of outlandish, but I've actually seen that before. So just make sure that what you're doing is reasonable. And then, the education of the staff and providers, once the dashboard's set up, once you've got your workflows in place, it's all about, does the right person know the right thing to do at the right time to capture that data, right? You get a new MA or you get a new provider. They don't necessarily know what they're supposed to be doing within the EHR to capture that data, or things change. People, like I say, people leave, they go on vacation. So make sure that your providers and your staff know exactly what they're supposed to be doing to be successful. If you've got, an issue of who's on first, then obviously you're not really going to be able to improve the quality of healthcare for your patients. And finally, things people don't think about, their claims data. There's so many measures, and I've come across this so much this year, so many measures that can be submitted through claims. If you've never stopped to really take a look at, your claims data and, understand if you're collecting measures around claims, do you understand what the specification actually reads? Do you understand what encounter codes need to be collected and what G codes need to be added to those claims? If you've already got some kind of, disruptions, or let's say you've migrated to a new EHR and your claims are sort of out of whack, it's certainly not going to help your cause with regard to any of these value-based programs. So that's something that you want to maybe take a step back and, make sure that those are in good working order, things aren't falling through the cracks, because that will trickle over onto the quality side. Rest assured, it happens every single day. So just to kind of wrap it up, like I said, I wasn't going to take the whole hour, and I still won't. But the key things when putting this little kind of briefing together is that it's not that hard to succeed in MIPS. But just bear in mind that, this year, to avoid any penalty, you're going to have to work a little bit harder. You need at least 15 points. To be eligible for any bonus money, not just a positive payment adjustment, but that bonus money, that extra $500 million, you've got to score at least 70 points across the whole, the entire, all 4 categories. And I've driven this point home several times through this presentation, but value-based care, it's not going anywhere. But I also like to see that at least their CMS is listening. They're taking feedback. Like I said, they've thrown a few bones back. They've lessened some of the really stringent requirements for 2018. We did hear, like I said, in the news, the rumblings of the different types of payment programs that may come down the pipeline. So those are just all things to kind of be aware of. But in the meantime, you can't really stop what you're doing because the train has left the station. Okay. And ultimately, what I've said this entire hour, you need to be thinking about this. You need to start now. Cost started in January and quality started in January, but if you start that second quarter, you guys, it's almost April 1st. You really get your ducks in a row and you start collecting this data. You're putting yourself in a really good position to hit that 70 points, or to avoid the penalty if that's all you really want to bite off right now. So yeah, that's pretty much, I think, the 4 key points, the overarching points, I suppose, from that I took from going through the final rule and putting this together today. All right, Stacy, that pretty much sums it up, guys. I don't know if you have any questions. I'd be happy to, if you do, shoot me an email. I'd be happy to, reach out and discuss anything for 2018 with you. Or, send Stacy an email. She can put you in touch with me. My email address is right there on the screen. So that's all I have for today. So, Stacy, I'm going to turn it back over to you if anyone has any questions.
Great. Thank you, Carrie. I will get the copy of a presentation to all of our attendees today. Again, thank you all. And I'm going to leave the question box open for a little bit in case you all have questions. And Feel free to submit them through there, or I think you should be able to unmute yourself if you have questions as well. So again, thank you, Carrie, and I'll leave this open for just a few minutes.